Okay, Anissa, everybody's in from the waiting room right now.
Perfect. Well, I'm going to go ahead and get started. So thank you all for joining us today. Welcome to Indiana's first virtual Rare Disease Day event. We're really excited to be celebrating Indiana's rare disease community today with all of you. So I'm actually going to kick it off with two brief videos from NORD. So I will pull those up in a moment here.
Hi, Tristan.
We're not getting any audio through the stream.
Okay. I know what I'm doing here.
It's okay.
See.
Anissa, before you do the full screen and the share, you have to click those two boxes in the lower left corner again.
Okay, that's right. Okay, I am going to.
When you go to, you got to stop your screen share.
Okay.
And when you choose the screen, there should be those two little boxes in the lower left corner.
Okay, perfect. Here we go. Thank you.
In the United States of America.
In Australia.
Malaysia.
No Brasil.
Tunaishi Kenya.
My passion is for fashion and design.
I love to dance.
Menyusur hutan.
Para viajar e descobrir novas culturas.
Anapenda kunitazama nikipuliza mapovu.
Jeg elsker idrett og spiller spill med familien min.
Minhas paixões são minha fuga quando as coisas estão difíceis.
Ada hari-harinya apabila melakukan perkara yang biasa akan jadi sangat susah.
When your disease makes you feel isolated.
It's difficult to walk.
Å være med på laget.
When I'm tired.
Afraid.
O controle da doença pode ser desafiador.
Atau mengecewakan bila saya kehilangan masa.
Muda muhimu sana.
But we learned to be resilient.
Para apreciar os pequenos detalhes que me trazem alegria.
Kumwona mtoto wangu wa kiume anavyofurahi tunapoenda nje, nikijua anasikiza hadithi na sauti zilizo karibu.
Mencari titik perhubungan dengan masyarakat yang tak pernah saya sedar wujud.
Å være uavhengig på grunn av menneskene rundt meg.
Their fierce support.
Sua bondade inabalável.
The big love.
Mine venner.
Keluarga.
Enfermeiras.
Doctors.
Support workers.
Assistenter.
Mashirika ya wagonjwa.
Together we are a strong community.
Nimeweza kuelekewa.
Histórias compartilhadas que me libertaram das dúvidas.
Og ga meg selvtillit.
I am Tristan. I live with sickle cell.
I'm Angelina.
And she has CASC, a neurological disorder.
Saya Syafiq dan saya hidup dengan ectodermal dysplasia.
Regina, eu tinha leiomiosarcoma, câncer raro.
Huyu ni Harvey, ana SMA, spinal muscular atrophy.
Jon Christian og jeg har OI, medfødt benskjørhet.
Esta é minha vida.
Suara saya.
And I am more than my disease.
We are rare.
Kami ramai.
Nós somos fortes.
And we are proud.
Whoops. All right. Well, I seem to have exited out on accident of the other video that I was supposed to show. So I am going to leave that one out for now since I know we need to be time sensitive. So I'm going to go back to our slides here. So this is a brief disclaimer that just mentions that NORD is not providing any specific medical advice and we are not a healthcare facility. So heads up on that. Perfect. So I'm going to turn it over to Sunny and John to introduce themselves and to welcome everyone.
Good evening. My name is John Toomey. I am from Indianapolis, and I am a co-state ambassador along with Sunny. And my rare disease was Guillain-Barré syndrome in 1997. With that, I'll hand it over to Sunny.
I'm Sunny. I'm the co-ambassador for the state of Indiana. Very excited to be here. My rare disease is septo-optic dysplasia, which I'll get into when I share my story here in a little bit. It's a fun one. And we can go ahead and hit the next slide.
It's my pleasure to introduce Representative Greg Porter. He has been in the state legislature for 14 terms, which equates to about 29 years, he just told us. He's also the external vice president of Health and Hospital here in Indianapolis. And Greg and I have known each other for a long time. We first met at Shortridge High School here in Indianapolis and played football together. Greg went on to play at Earlham, and I pretty much rode the bench. Greg, welcome.
Thank you, John. Good evening, everyone. It's truly a pleasure to be here with you this evening. And I think what you're doing is truly God's work in educating the public and moving toward education that we need to understand here within the state of Indiana. Again, I'm Greg Porter, state representative here in Indianapolis, House District 96, which takes in small communities of east end of Mass Avenue, up to Harry Morton, Kennedy King area, Mapleton Fall Creek, Butler Trockington area, Lower Park, Butler University, and all the way up to around 61st and Michigan Road. So a very wide range of individuals. And further east, it goes all the way over to around 38th and Keystone. So as you can see, we have a very wide range of communities that we represent, and we're very blessed to be there. I currently serve on Ways and Means, which is your budget committee. It starts in the House. I'm a ranking member of Ways and Means, and just yesterday passed the first phase of a $35 billion budget for the state of Indiana. I also serve on public health and also financial institutions here in the state of Indiana. I want to share a little bit. My connectivity is I served on sickle cell board here in Indianapolis for about 15 or 16 years. I've been a big advocate when it comes to sickle cell and being an advocate for them and getting funding at the state level. We've been able to put more money toward sickle cell and other programs of health in the state of Indiana. Not as much as we could, but we will continue to strive to address those needs of our constituents. One thing that I want you all to know is that you have to be involved in the political process. As you well know, there's 16 states that have advisory councils. There's no reason why this state should not have one. It is my understanding that 6 states have passed legislation in 2020. And what I would say to you as a family, now is the time to start working on the next year's legislative agenda for your organization. The rare disease advisory councils can bring so much to the table. We've done newborn screening. If you look through the General Assembly in the last 10 or 15 years, we've done a lot of set policy for a lot of issues in regards to newborn screenings or health in general. But I would tell you, ladies and gentlemen, it isn't enough. And the reason why I say that is because even though we have newborn screening and other programs like that, in the last 10 years, we have reverted back to the general fund over $1 million. That's right. The money was allocated, but it was not spent. And so sadly, when it comes to programs like that, we reverted back to the general fund and they get used for something else. So that's where you, ladies and gentlemen, come into play to help build a program to show the statistics why it is important and not to revert those dollars back to the General Assembly. I'm really excited about being here tonight. You as the stakeholders have more power and more influence than you think you have, because in the General Assembly, when something affects that individual member, it becomes a big issue. When it doesn't affect them, it's not a big thing to them. Case in point is that 3 or 4 years ago, Representative Gutwein did a newborn screening for health disorders in 2019 because someone in his family was not screened appropriately for a disease, and that prompted him to step up to get a newborn screening for Hurler syndrome. So it can be done. It may take a year or two, but when you start early and try to get it passed without having a fiscal impact next year, then the following year, we can try to put money in the budget to address the concerns for our community. With that, ladies and gentlemen, I thank you for inviting me. It's truly a pleasure to be here, and I look forward to hearing from the other speakers.
Awesome. Thank you so much.
Yeah, thank you, Greg. Before you go, I want to say the newborn screening effort, really important, especially to, in my case, I wasn't diagnosed until I was 13. And if newborn screening had been more, commonly in place here in Indiana when I was born, they might have caught it when I was born. And I could have gotten treatment right away, but it is what it is, I suppose. Let's work on making it better. I appreciate your efforts, so thank you.
Thank you.
Oh, sweet. Okay, next up, we've got somebody that I'm very excited to share with you today. Dr. Eric Emel is my personal endocrinologist, as well as a very active medical professional in the rare disease community. He's great. He's got a lot of awesome stuff to share, and without further ado, please take the stage. I can't wait to hear what you have to say.
Thank you, Sunny. It's a pleasure to be involved in this and to share some about how my experience has been in involvement in rare diseases and in researching rare diseases. So I'm an endocrinologist at IU School of Medicine and at Riley Children's Hospital. I'm a little different than most specialists in that I'm trained and certified in both adult endocrinology and in pediatric endocrinology. Because of that, a lot of my research is actually focused on some genetic disorders. And I've spent a fair amount of time thinking about rare bone diseases in particular, although obviously I have some patients with other rare diseases as well. One thing I do tend to find within a medical group is that if you get known for knowing a particular rare disease really well, people think of you when they have some other rare disease that you might not actually know much about, but then you end up learning about it. And I think that's been a lot of fun. It's been very exciting. And as a doctor, I know that patients find it very rewarding when someone is willing to step outside of their comfort zone and learn a little bit more about their rare disease. So first I want to talk about, why do researchers study rare diseases? So there's the very obvious reasons that they've met a patient or have a family member that has had a rare disease. They may have a rare disease themselves. Sometimes that's a stimulus for someone to go into research. I certainly know some researchers with osteogenesis imperfecta that went into research because of their experiences as a child. We want to understand the disease better. We want to be able to diagnose the disease better, to develop treatments that will improve your health, your life overall. And then there's another side of rare disease research that isn't always recognized. And that is, there are so many areas for which we know the mechanisms that underlie how things are normally supposed to go because of research done in a disease where that process wasn't going properly. So in my area, we learned about how the body handles phosphorus because of diseases where the body wasn't handling it appropriately and they developed bone problems. And so studying a rare disease or a genetic disease especially can often tell us things we didn't know about how the body normally works, which I think is fascinating and amazing. And sometimes that process comes up with new treatments, not just for that rare disease, but sometimes new treatments that are relevant to much more common disease. For example, there's at least one medicine in osteoporosis and some others that have been studied that are designed to increase bone density, but they came out of diseases where something was abnormal in that pathway that was causing an abnormal increase in bone density. And so we learn a lot about how things are regulated and how to adjust things. So what is a rare disease? So it's important to know that the definitions vary in many different countries. In the United States, I believe this definition was laid out in the Orphan Drug Act originally. It's a disease that affects less than 200,000 people in our population of the United States. In Europe, it's a slightly different number. It's a disease that affects less than 1 out of every 2,000 people. But of course, some diseases are rarer than others. And so instead of just having the zebra here, I have the zebra here, I have a unicorn as well. So if there are 331 million people in the United States, a common estimate is that there are about 7,000 rare diseases. And so each disease is rare, but collectively rare diseases are very common. And one would estimate that somewhere between 7.5% and 9% of people have a rare disease. So that means that if you are, in a, classroom with 20 people, there's probably 1 or 2 people in that classroom that have a rare disease. Maybe not, but just statistically speaking, that's certainly a possibility. So if that's the case and rare diseases are so common, why is it difficult to find a doctor that knows about my rare disease or that is able to make a diagnosis or carry you through treatment or additional evaluation? And here's where I want to put out a case for understanding some of the limitations that our doctors have. So if I've told you that almost 9% of people will have a rare disease, and there are 7,000 rare diseases, how many of you know 7,000 different topics in depth? And so that first off really lets you know where that, what kind of a burden that would be. So if we assume these numbers and we assume that the average primary care doctor probably has a panel of about 2,500 patients. So they would have, mathematically, they should have about 225 people who have some rare diseases. If each one has a completely different rare disease, that means they may have seen just 225 different rare diseases out of 7,000 possible. And, in reality, it's not an efficient use of their time to spend time to learn about every rare disease that they might never see when they need to be really up on diabetes and heart disease and hypertension and arthritis and all of these things that their patients are coming in to see them with every single day. So I think this is important because it reminds us our doctors are human too. And they have to put their effort where they see the most results. Now that being said, I hope you all have doctors that are willing to, once you've found a rare disease, to learn enough about it to help you. Now that still may mean that it's enough to help you get to the right specialist. Because it is true that these things do sometimes become concentrated as you get into different subspecialties. So the patient journey with a rare disease varies. And some of this is going to vary depending on whether it's a condition that is present at birth or that has symptoms that are evident at birth or sometimes before birth, or if it's something that develops over the course of several years in childhood or in adolescence or adulthood. It differs depending on whether it's genetic or there's some critical exposure that's required for developing a disease. But patients will have symptoms, sometimes briefly, sometimes for a long time, with various amounts of testing before they come to a diagnosis. And at every step, patients may need to go backwards. Patients and their doctors may need to go back a step and reanalyze, because maybe the diagnosis that seemed most obvious was wrong, and we need to go back and rethink. I'm a firm believer in medicine that it's really useful to periodically rethink what I think I know, because sometimes I come to the same conclusion and sometimes I find something new, and that's always going to be beneficial. Even once you've made a diagnosis, often there's more testing. Sometimes it's following serially for additional things. Sometimes new symptoms develop and you have to figure out, is this part of the same condition or is this something extra? Patients with rare diseases don't just get rare things. They're going to also have the similar risk to the general population of the more common illnesses, of getting pneumonias and ear infections and everything else that everybody else gets. As you go along, hopefully you find a treatment that's appropriate to your rare disease. Some rare diseases don't have a specific treatment. Some of them have a more specific treatment. And again, ongoing monitoring over time. Well, it turns out the research journey is very similar to this pathway. A disease is first described based on various features, and we start to learn as we go from left to right here through more about the natural history, more about things that develop in those patients. Sometimes we develop new tests. Sometimes there are old tests that are very appropriate for screening and managing those patients. And it's often after this has been going on for a long time, maybe decades, that we actually discover what the underlying cause is, whether that's a gene or a particular infection, something that's autoimmune or inflammatory in nature. Certainly there are tumors and other environmental exposures that all can contribute to various rare condition syndromes. Over time, we may develop new tests. Sometimes that's a specific gene test. Sometimes that's a biomarker in the blood or the urine or some other imaging tests that can be developed. And ideally, eventually, treatments are developed. But there's a pathway involved in developing treatments. Treatments are usually tested in small numbers of people at first, because we have to prove not just that they work, but also that they're safe. Researchers do a lot of work, sometimes in cell culture models, sometimes in computer models, and sometimes in animal models. But all of those things sometimes fall apart once you put them in humans. I've certainly been a part of pilot clinical trials. That's a word that we use in research for small trials that we're doing to try to prove something works enough to put them in a bigger clinical trial. That's just a research study where we're trying to understand and develop a new medicine. And I've been involved in some studies where colleagues' work in an animal model really seemed like something would work, and we did the same medicine in people, and it didn't have any effect that we were looking for. And so we abandoned that and start to look for something else. Once you show that a treatment works well in a small number of people, and you develop a dosing strategy, then you have to treat them in a larger group of people. And then often you have to treat them in an even bigger group of people that's maybe not as sick as the first group, or that is, a lot of times we do the initial treatments in adults if it's a condition that also affects adults, and then we can move it into children if it's a condition that also affects children. And then eventually, and this can be a long period of time, there can be a new treatment available. But even once there's a new treatment available, sometimes you still have to learn more about the natural history and about what are the other complications that the medicine may or may not be able to prevent. One good thing about living in the time that we live in now is that genetic testing is much more readily available for many diseases. It is, however, difficult often to get covered by insurance. And so that is an important factor, certainly from an advocacy standpoint. then these are challenges that patients and doctors end up facing together. But genetic testing is sometimes important for making a diagnosis. Sometimes it's not so important for making your diagnosis, but for giving you guidance for your children. Because sometimes once we've made a genetic diagnosis in a parent, then we can just test that gene in the child and figure out, oh, we need to start treating them early or screening them early, or we don't. And either one of those is a useful bit of information for the doctor and the family. I do want to put in one plug for something that a colleague of mine at IU and Riley has going on, which is the Undiagnosed Rare Disease Clinic. And this is Dr. Erin Conboy. She's a geneticist at Indiana University School of Medicine. And this clinic has sort of two roles. It involves clinical care, but they're also interested in research. This includes working with very high-end genomic sequencing, and with intentions over time to partner with people doing basic science labs to try to help characterize new mutations in different genes that could explain why and how they're causing a given disease. You may have heard her name sometime, I want to say it's probably been sometime last fall. She was there was a story about her on at least one of the local news channels about her in this in her program, and telling a wonderful, warm, fuzzy success story. So that's always nice. So what about participating in rare disease research? So broadly speaking, I like to encourage patients to participate in research. Sometimes it's research I'm involved in. Frequently it's not, because I'm only involved in research in certain rare diseases. But research is very broad, and research is not always giving you a medicine. There are lots of things that need to be done to help us better understand any given disease. So that includes observational studies, or something we call natural history studies. That may range anywhere from keeping track of the clinical records as a patient is seeing a group of doctors in a specialty, to collecting blood samples, or doing specific different kinds of imaging to follow things over time. That can include something called registries, which vary from registries where your doctor in their office is putting in information about patients in a registry with a given disease, all the way to registries where patients themselves are putting in information about their symptoms and their disease over time. The best registries usually have some verification processes where doctors that are involved in the study have to sort of verify that that person really does have this disease, because that makes sure that the information is clear and accurate. But so I think that's important. And I've certainly been involved in natural history studies and in registries, and even in one study currently that's funded by the NIH, that's a combination of the two. And then there are things we call clinical trials. And I've said that word a few times, but if you don't know what a clinical trial is, I guess it's not that different from a legal trial. In a legal trial, you're sort of trying to find out the truth. You're sort of trying to figure out what happened and who it happened to, and how. In a clinical trial, we're trying to do the same thing. We're giving we're trying a given treatment or a test, or sometimes it's a medical device, or sometimes it's some new form of physical therapy, or various things like that, and trying to see how well it works. The NIH basically defines a clinical trial as you're doing some type of intervention to a patient population with the goal of figuring out how it works, and as a, in general as research. And sometimes these are, like I said, new medicines. Sometimes these are studies of existing medicines put to a new use, or sometimes we have to compare this drug that we've been using for a long time to this other drug that we've been using for a long time. And in those cases, you might ask, well, why don't they just use whichever one's best? Well, the way we find out which one is best is by doing trials like this. And we do them when there is substantial evidence that we don't know the answer. And these things can really change overall the paradigm of treatment over time. So as a brief example, though, of how long this can take, I work in X-linked hypophosphatemia. If you went to different bone doctors or the American Society for Bone and Mineral Research, the thing that other people will know me for is work in this particular disease. So this disease was discovered long before I was born, in 1937. And for years, really most of the treatments or most of the studies related to natural histories and some attempts at treatment. By the 1980s, what has been the conventional therapy since then was developed, which was a medicine called calcitriol, which was a certain special kind of vitamin D and phosphate salts. It wasn't until mid-90s that the actual gene abnormality was discovered. And then in 2000, incidentally at Indiana University, but not by me, the gene for FGF23 was discovered, and this all began to be put together. I came in around 2003 in my endocrine fellowship and got involved in this process and spent a lot of time doing additional studies of existing treatments and natural history studies. And then in partnership between many academic institutions around the world, along with some pharmaceutical companies, a treatment that was directed at this protein called FGF23 was started. And again, the first dose was actually probably done here. It was either that or a placebo. But over time, and in another 9 years, this antibody treatment has actually been approved for therapy for XLH. And if we get time later, I can talk a little bit more about that. But one of the things oh, sorry, that's just me popping up in there. One of the things I wanted to highlight, though, is at every point during this process, natural history studies are still important. Because we are still learning more. Once a medicine comes out, we don't actually know everything about how much it benefits all aspects of the disease, and we don't always know what the long-term side effects are. So we may know a lot about short-term side effects, but all of these things require ongoing research and patient participation. So new treatments can only be developed through research participation. Research often means you're working with national experts in the field, but I also want to remind you all that research is voluntary. All of us that are involved in research really feel it's important that you're only doing it because you want to participate in it and that you feel like it's the best thing for you. But again, while research is voluntary, we really do need volunteers in order to make advancements. So thank you for letting me share.
Thanks. Awesome presentation. Seriously, we're really lucky to have had you join us tonight. And I know another one of your patients is actually here. Brittany says that you help her with her bone condition as well. So that's pretty neat. Small world.
Small world.
That's awesome. Anissa, I think at this point, would you like to?
Sure, yeah, I will hop in. Well, thank you so much, Dr. Emel. And towards the end, we're going to give some extra time for Dr. Emel as well. So if you'd like to stay on the line and learn a bit more and ask some additional questions, then you're more than welcome to. So I am Anissa Reed. I'm the State Policy Manager for the Eastern Region here at NORD. I'm going to talk a little bit more about Rare Disease Advisory Councils and why we feel like they are so important. So let's start with the problem. So more than 25 million Americans are living with one of more than 7,000 unique rare diseases. That breaks down to about 1 in 10 Americans. So even though that may seem like a lot, state decision makers still have limited awareness of the issues and impact that rare diseases have on patients, their caregivers, and their overall healthcare system. So what is the solution? NORD believes it's to create RDACs, a diverse body to advise state government on the common obstacles that the rare disease community faces. We see this as an enormous opportunity for government officials and the rare disease community to work together to develop resources necessary to prevent and address barriers in a strategic way. So there are a number of differences between RDACs in different states, including the number of members on the council, varied members of the rare disease community represented on the council, differences in where the council works out of, funding, and duties and accountability mechanisms. So overall, each RDAC has the same goal of supporting the rare disease community by increasing the voice of rare disease patients and caregivers at the state level. So to date, we have 16 states that have passed RDAC legislation. We are also excited to report that we have several other states with legislation that's been introduced. We recently had Virginia's General Assembly pass their RDAC bill through, so it is now on the governor's desk. So we are anticipating it to be signed within the next few days. So soon to have 17 RDACs, which we are so excited about. So we want to continue increasing the number of RDACs to give as many rare disease patients and advocates a voice in state government. NORD highly encourages that different state RDACs collaborate with one another to share ideas and best practices. And we plan to continue to develop and release toolkits and one-pagers, host webinars, and convene additional meetings to support ongoing RDAC work. So with that being said, so where is Indiana in their RDAC process? So at this time, Indiana does not have a RDAC in place. However, we have several great advocates in this state who are passionate about rare disease advocacy. So within the next month or so, we are hoping to begin building a diverse coalition to discuss what the rare disease community in Indiana would like to see in an RDAC, and to work together to put legislation across the finish line. So if you're interested in getting involved in these efforts, then please send us an email at rdac@rarediseases.org. And I'm also happy to answer any additional questions about RDACs and the coalition building process towards the end. So now I'm going to briefly jump into an overview of an important tool that we use at NORD. In 2015, NORD launched its State Report Card project with a goal of evaluating how effectively states are serving people with rare diseases. This year marks the 6th edition of the State Report Card, which was compiled using data current as of November 2020. So these are the policy issues that NORD's report card focuses on. It is important to note that these are not exhaustive. These issues touch on several critical and relevant policy areas at the state level, but with each issue included, there are so many others that are capable of impacting the lives of rare disease patients. So how do you find out how your state measures up? So you can select yours by clicking this link that's up here. Each state has a page that is also available in a printable version. So I am going to, this link has been a little bit funky, so I'm not going to share this video right now, but I'm happy to send it out to everyone. And it really walks you through the report card website and how to find additional information about the policy issues that we grade on. So these, again, they're just small snapshots of some policy issues that impacted the rare disease community in 2020. Current legislation and changes that have been made so far in 2021 have not yet been captured. So if your state recently passed legislation to improve one of the policy issues, they might not have a really high grade on it in our 6th edition, then you're likely to see it changed in the 7th edition. So the website provides a detailed overview of the data, and you can learn more about each policy issue in the methodology section that it has. If you have any questions about our report card, then you can always send us an email at policy@rarediseases.org. So I am going to, with that, go ahead and hand it over to Sunny and John to share their story. Thank you. Oh, you're muted there.
I was, thank you. It's that Zoom effect. I'll go ahead and get started with my story, and then I'll hand it over to John when that's over with. So, again, my name is Sunny, and I was born with a congenital rare disease called septo-optic dysplasia, which caused further complications with diagnostic names that are just as long and complicated. But basically, my pituitary gland doesn't produce hormones sufficiently enough to sustain my body on its own, and I'm completely blind in both peripherals. What I said I do have is limited and not very good, so I can't legally obtain a driver's license or read a book or look at screens for very long without suffering some pretty annoying headaches. Of course, this doesn't stop me from enjoying virtual reality, playing video games, and creating artwork. The stubbornness of nerdy creative types like myself knows no bounds. Those hobbies aside, my favorite thing to do is volunteer as an advocate for others with my conditions, as well as rare diseases in general. I didn't receive a diagnosis until I was 13 years old. It was around that time when it was pretty clear to everyone around me that I wasn't growing like I should. While my peers hit developmental milestones, I was lagging behind, becoming more frail and frequently falling ill. My parents took me to Riley Children's Hospital in Indianapolis, where I met my first endocrinologist, Dr. Emel, who we're honored to have speaking tonight. It's pretty common for those of us in the rare disease community to search for years before finally getting the right diagnosis. But I guess I hit the jackpot. Dr. Emel knew exactly what I had just by looking at my short stature, developmental delays, and always slightly twitching eyes. Excuse me. He called for the appropriate tests, and sure enough, he had been correct. I had all three indicators of septo-optic dysplasia. Dr. Emel and his team explained the situation to my parents, and we began the treatment plan that I would be continuing for the rest of my life. From the time of my diagnosis until I hit adulthood, I didn't really know much about my own disease. I knew I had to take a bunch of medications, but other than that and the annual visits with Dr. Emel, I just didn't bother thinking about it. My parents told me that as long as I took my meds, I was just as normal as my peers. Though that was a nice thought, and it allowed me to not worry about my diagnosis for most of my life, it wasn't entirely true. That became evident in high school when I really started struggling. It was clear to me that I had much less stamina than my peers. I knew it had to have something to do with my rare disease, but I knew so little about my diagnosis, and I didn't have the resources to look into it, so I had no idea that the intense fatigue and weakness I often felt were actually known symptoms of my condition. I had to work extra hard, and sometimes I had to boost my energy with coffee every day in order to keep myself awake in school, but it took an extra, year and a half and the help of a credit recovery class, but I was eventually able to graduate. My first job was as a clerk at a convenience store, and I loved my job there. But after a while, I began getting sick more frequently, and at one point, I'd been missing work so often that it was starting to have a negative impact on the store. So I decided to quit and focus on my health for a while instead. That was when I moved into my first house with my partner, Justin. And at that point, I realized that moving out on my own meant that my dad would no longer be in charge of my healthcare. It was up to me to keep up with the appointments and eventually handle my own insurance. Thanks to the Affordable Care Act, I was able to stay on my dad's insurance until I turned 26. Honestly, that coverage very likely saved my life, because at this point, I still didn't fully grasp how serious my rare disease was, and without good healthcare, I wouldn't have been able to afford the visits or lab tests that I needed. I very likely would have decided to save money by not doing everything my disease demands of me without realizing how potentially fatal that frugality could be. The long drive to Indy to visit Dr. Emel wasn't really feasible at the time, so I searched for a new endocrinologist closer to home. I found one right here in my hometown who claimed to know how to treat my condition, so I transferred to his care, where I remained for the next couple of years. He convinced me to start taking growth hormone shots again as an adult, and my quality of life greatly improved. About a year into his care, I returned to the workforce, thanks to the increased stamina granted by the shots. But only after around 6 months of work, my health declined again. I became sick more frequently, and my body felt as though it were getting weaker every day. I experienced my first diagnosed adrenal crisis, a complication from my condition, which can be fatal if not treated properly. I eventually became too sick to continue working, and I had to quit. Having lost another job due to illness, I decided to seek disability so that I could support myself financially, since it was clear to me that I wasn't able to work for a paycheck. When I expressed my concerns to my endocrinologist, he told me that he refused to support my disability claim. I felt like I had hit a dead end. One of his nurses noticed what was going on and privately told me that she thought that I should seek disability despite what he had said, saying that he had a personal issue with disability support in general and that I should seek a second opinion. So I did, and it's a good thing too. Because I wasn't very well educated on my own condition, I had no idea how poorly he'd been managing my adrenal insufficiency. I got a second opinion from a new endocrinologist, and she informed me that he had me on such a high amount of steroids that if I had remained on that dose, the consequences could have been devastating for my health. Needless to say, I transferred to her care immediately. She got me on the proper dosage, and she did a great job managing my care, answering my questions, and helping me to understand my rare disease better. She also supported my disability claim, which I eventually won. I remember her saying, "Your full-time job is being your own pituitary gland." This was when I started to really grasp what my diagnosis was, and my experience with the endocrinologist before her inspired me to learn all I could about it. While looking for information on my condition online, I realized that the only resources available were boring medical journals filled with complicated jargon that could be really hard to understand at times. I found awesome videos made by patient advocates sharing lives with their chronic illnesses, but when I first started looking, I couldn't find anyone doing that for my condition. So I decided to fill that void by making my own videos. I had been making videos on YouTube for about a year or so when I received a message from a man in another country. He opened up to me that he has my condition as well, and he shared that in his country's culture, it's frowned upon to speak openly about health issues, so he didn't have anyone to talk to about it, but he had seen my videos and thought I might be able to help. He had heard that people with our condition often can't have kids, and if I asked if I had any advice for him, as he was about to get married and he was worried that he wouldn't be able to give his wife children. I was able to ease his fears a little by sharing what I knew about fertility treatments that can help. I suggested that he contact the doctor in charge of managing his care and ask them about the possibility of starting those treatments. He thanked me for the help and said he would talk to his doctor. Around 5 years later, I received a message from him on my Facebook page. He said he wasn't sure if I remembered him or not, but he wanted to tell me that he still loves my videos and encouraged me to keep up the good work. When I saw his message, I immediately replied, telling him I did remember him and asked if the fertility treatments had helped. He told me they did, and he's now the proud father of a happy 5-year-old girl. He shared a photo of his family, and my heart was so overcome with joy and happiness for him. I know that he likely would have discovered fertility treatments without my help, but knowing that I was the one who had initially told them about him and seeing that my advice led to a beautiful child being born to a family who loves and cherishes her is a wonderful reminder of what a truly positive impact advocacy work can have on someone's life. Just last Friday, he reached out to me again and told me that his wife gave birth to their second child. I asked him if I could share a story with you all today, and he enthusiastically said yes. He gave me these photos to share and said, "Tell everyone that I love my life." So this is him and his family. It's a beautiful little family there. It makes me so happy to see that, you know, the simple advocacy work that I did had touched them so much on that level. That really keeps me going. So I hope that showing you just how fulfilling, I hope this showed you just how fulfilling and important being an advocate for rare diseases really is. If you're interested in learning how you can get started as an advocate, please feel free to reach out to us and we'll be happy to talk with you about it. Thanks. John, would you like to share your story? Oh, you're muted.
Nope, still muted.
Yeah.
There you go.
Of course, I'm muted. Thank you, Sunny, for sharing a very heartwarming story. My rare disease is an autoimmune illness called Guillain-Barré syndrome, also known as GBS. In 1997, I was 41 years old and in excellent health and started experiencing some back pain over a weekend. Went in and saw a neurosurgeon. They immediately did an MRI. They thought that maybe I had done something to my spine. It came back clear, and they prescribed heavy-duty painkillers and heavy-duty muscle relaxants. This was on a Monday. By Friday, I couldn't walk. So they sent an ambulance to take me to the ER, and they did some tests like a spinal tap and discovered that I had Guillain-Barré syndrome. Immediately administered IVIG, which is a blood product, a human blood product, also is known as immune globulin. I was in intensive care for 3 weeks. I was in a medically induced coma because my vital signs were going the wrong direction. But when I woke up, I started to get a little bit better. I couldn't feed myself. I couldn't shave. I couldn't do anything, let alone walk. I was in the medical hospital for another week, and then they transferred me by ambulance to a rehab hospital where I forgot to mention, when I was in ICU, I was on had a tracheostomy, was on a ventilator, feeding tube, and was out of it in the coma. When I got to the rehab hospital, they started intensive physical and occupational therapy. And after 5 weeks, I was able to walk out with a walker, and then came back as a outpatient, and they immediately promoted me to a cane. And then today I'm 65 years old. I ride my bicycle. For those of you who know about the Hilly 100 down in Bloomington, I've ridden it more pre-GBS than post-GBS. Beg your pardon, more post-GBS than pre-GBS. I'm a little nervous, sorry about that. And I do yoga, I play tennis. So my rare illness was not chronic, it was one and done, thank God. There is a similar illness called CIDP, which stands for chronic inflammatory demyelinating polyneuropathy, and it is chronic. And it requires IVIG infusions every 3 to 4 weeks. If you ever drive around your town, you see a plasma donation center. Those people are doing wonderful work gathering human plasma to convert to IG for GBS and CIDP patients. Couldn't have made it through without help from friends, family, neighbors. And today I've got just mild neuropathy, but no complaints.
Great. Thank you so much for sharing, John. Both of you, Sunny, John, inspiring stories, and we're so lucky here at NORD to have them as our volunteers. So in the chat box, there was also, if you are not a Rare Action Network member, there is a link and it's easy to join. You'll get alerts and updates for different events happening in the rare disease community for Indiana. So we're always looking for great advocates to work with us. So I'm going to go ahead and attempt to share my screen again here. Okay, so after the event, we are going to be randomly selecting 2 winners from the attendee list to receive these Rare Disease Day swag bags that are seen in this picture. Winners will be contacted via email this week and receive their prize pack sometime in mid-March. So thank you and good luck with that. So as a closing here, I'm actually going to stop sharing my screen. 1 second here. And I would love to open it up for any questions that folks might have for our great speakers about what an RDAC might do. And then if there are no questions, then I'd like to hand it back over to Dr. Emel to provide us with some additional insight. So I'll give it a second here. See if we have any questions. And you can also come off mute if you would rather speak.
Don't be shy.
It's interesting. I noticed in the chat, Sunny, it looks like a lot of individuals here have a similar condition to you. So
yeah, adrenal insufficiency. There's primary adrenal insufficiency, which is an autoimmune condition, more commonly known as Addison's disease, and secondary adrenal insufficiency, which is what I've got, which is caused by the issues with my pituitary gland. So it's pretty neat that we've got that in common. Stinks to have it, but it's neat that we know what it's like.
To make things more complicated, there are even more causes than just those 2.
Oh, I'm sure. Yeah, I probably oversimplified it. For sure.
And I am actually also going to play a quick thank you video. I'm going to reshare my screen here and hopefully the video behaves itself.
Every year on the last day of February, the National Organization for Rare Disorders joins together with others around the world to raise awareness of the challenges faced by people living with rare diseases. Achieving health equity is even more difficult for rare patients. To have equity in health means everyone has an opportunity to be as healthy as possible, regardless of social, geographic, economic, or other obstacles that may be working against them. At NORD, we appreciate your support, which allows us to work on issues like health equity and many others, and for our staff and volunteers to bring them to the forefront on Rare Disease Day.
From the volunteer state ambassadors, we would like to say thank you to all of our Rare Action Network supporters for helping us connect with rare patients and families in our states.
And thank you for allowing the Rare Action Network to raise important issues with state lawmakers on Rare Disease Day and throughout the year.
Did you know that in medical school I was told, when you hear hoofbeats, think horses, not zebras? But what about the more than 25 million Americans living with a rare disease? At NORD, we are humbled to provide help and resources to our zebras and their caregivers.
NORD support allowed me to catch up on some overdue bills, including my rent. Thank you for your support, NORD, and thank you for supporting Rare Disease Day.
From all of us at NORD, thank you for your dedication to the rare disease community on Rare Disease Day and every day.
Great. I'm going to exit out of that because earlier it automatically went to a fitness video since it is my YouTube channel. So I'm not going to risk that again. But again, I wanted to open it up for any other questions anyone might have. And also feel free to email Sunny, John, or I if you think of something a little bit later. So yes, would love to turn it back over to Dr. Emel. It's really interesting, as you might have seen, Dr. Emel, a lot of people have similar conditions to Sunny that, so you might have a lot of knowledge on that as well to share if you want to dive deeper.
What was I going to say? I just made the chat box enormous. Didn't know I could do that. Yeah, so I think overall it's actually been great to be here with you guys today. I have I may have mentioned this at the beginning, but I've had a fair amount of involvement with some other bone specific rare disease organizations, in particular the XLH network, which relates to that disease I was showing you that timeline for, and as well as to some degree the Osteogenesis Imperfecta Foundation. And in the distant past, I had some involvement with the Fibrous Dysplasia Foundation briefly, and certainly have some friends who are on the medical side that are very, very involved in that one as well. I think that actually what you guys are doing in terms of, one, coming together for advocacy, but also for support, because there is a lot of there's a lot of support just in knowing not just that there are other people out there dealing with things that you are dealing with, but knowing who some of them are. Because it's one thing for your parents to say, oh, there are other kids dealing with this too, or your friends to say, yes, there are other people in the world that have this, but it's often very meaningful to actually meet somebody. So if this was in person, often that can be a very dramatic eye opener for people.
Yeah.
Thank you. And absolutely true. It's when I first started to really look into what my condition was, and like I said, when I was sharing my story, all I could find were those medical journals that were really boring and hard to read. But when I started to really reach out and found community, with other people that have my condition online, and we were able to kind of share similar experiences, it's so validating and really breaks that isolation that you can feel when you have a rare disease. So that was really awesome when I found other people that have my condition. And the rare disease community at large seems to have a lot of overlapping experiences when it comes to that as well.
And even though a lot of, there are more common rare diseases and less common rare diseases, and as you guys could see in the chat, even there are, and with your discussion about adrenal insufficiency, there are, it turns out there's a fair number of different rare diseases that have adrenal insufficiency as a component. And sometimes it's the primary component, and sometimes it's one of several things. And so that overlap, I think, is also important in general to recognize.
Oh, for sure. Yeah, and on the topic of adrenal insufficiency specifically, and drawing back into the topic of RDACs, this is something that we could really work on when we form an RDAC, which is, I know that in Indiana and a lot of other states, the protocol for emergency personnel, EMS personnel, makes it to where they can't use the emergency shot that we have to carry around with us at all times. Those of us that have adrenal insufficiency have a backup shot of corticosteroids in case we're in a traumatic event where our body would need a sudden burst of that cortisol. And if we're unresponsive and an EMS worker were to find us, and even if we had that shot on hand, the way that the laws are currently set up, they can't give us that shot legally. And Dr. Emel, I'm sure you already know that if we don't get that cortisol right away, that can have some serious complications very quickly. So if we could get that law changed, through work with an RDAC, that would be really great for a lot of folks that have adrenal insufficiency.
That's the reason we give people that as an option.
Yes,
it's to try to help bridge them to getting fluids and more hydrocortisone or steroid injections in the emergency room. It's that one you carry with you is supposed to be a bridge to help you make it there. So and that certainly can be a very big challenge. I would encourage all 4 or 5 people that mentioned that they have adrenal insufficiency to wear medical alert jewelry, because it's not just in the ambulance that there's a delay. It's sometimes once you make it to the emergency room, there can be a delay. And if you're with people who don't know that you have this, that medical alert jewelry can get you help sooner. And unfortunately, I actually don't generally recommend that you put hypopituitarism on there or Addison's disease. Actually, Addison's disease they might catch on to, but I usually recommend that you have adrenal insufficiency put on it, or cortisol dependent, because I want it to take fewer neurons to fire for the person in the emergency room to figure out what you need. I see,
Everyone's showing off their medical jewelry.
Their medical bling.
Mine does have a phone number on it. Please don't call Justin. He's sleeping right now. But
Are you the Vanna White of Nord?
Yes.
Great. Well, yeah, I mean, I think that I'm so excited that there's such a great group of people who attended this event. Indiana has so many passionate advocates. So I'm really looking forward to working with all of you. And again, the first step is building up the Rare Disease Advisory Council Coalition. So that just consists of anyone who's passionate about rare diseases, patients, physicians, geneticists, anyone who wants to come together and discuss state needs, and then focusing on getting that legislation across the line and connecting with policymakers to use our voices and share our stories. So that's something that we are very interested in working with all of you in. So I'm also going to drop my email address in here, because I don't know if I added that to a slide. Perfect. So you can send me an email at any time as well. And with that, I'll open it up for any other questions or any other closing thoughts tonight.
I want to mention that that Brittany brought up an organization called Danny's Dose. They were actually one of our speakers for the Living Rare, Living Stronger Forum this year for NORD, and they were absolutely fantastic. After seeing their presentation, I reached out to them, and I am actually working with Danny's Dose to kind of bring those efforts of improving EMS protocol for adrenal insufficiency, as well as other diseases that require emergency medication that EMS personnel can't legally use right now. So that is in the works. COVID kind of threw a wrench in that, but we're working on it. So just keep an eye out for that. And that'll definitely be something to tie into the RDAC when we get that started. And I'm seeing some support for the RDAC in the chat, so that's awesome.
Yeah.
I did want to mention that our events usually for Rare Disease Day are in person. but obviously because of COVID, we had to do virtual. Hopefully, knock on wood, we'll be in person next year. I did want to show this.
Hey, nice.
Awesome. Congratulations.
So I got my second vaccine or inoculation on Saturday. So I'm really, I feel great. I had a little bit of a headache that was resolved with 2 ibuprofen, and I've been fine.
Awesome.
That's so exciting. I can't wait to get that sticker one day too.
You're not quite old. You're not quite old enough, Anissa.
I know.
I have a couple questions.
Yeah.
My name's Sarah. I've really enjoyed this event. While we have Dr. Emel, I wanted to ask, what are the ways to get involved in the research?
That's a good question. So a lot of research studies are going to be specific to, generally speaking, they'll be specific to a given disease area. And sometimes that's a very broad, very common disease. Sometimes that's a much less common disease. And even as I was thinking about it, where there are things that more than one rare disease has a feature of that, like adrenal insufficiency, it might only be relevant to one, a given study might only be relevant to one particular kind. So sometimes you can ask your doctor, and your doctor may have some information. There's also a, what's the website for it? There is also something affiliated with the Indiana CTSI, that's the Clinical Translational Sciences Institute, and that's a collaboration that's funded by the National Institute of Health to support some of the research infrastructure on campus. It's actually shared between IU and I think Purdue's involved and Notre Dame's involved. But on their website, there is a link to, participating in research. I don't remember exactly where it is or how it's located, but there is an IN research or an Indiana research link within the Indiana CTSI, and you can go on there and sometimes see studies that have been listed there that are enrolling with some contact information, or you can actually submit through that system, and I believe the research coordinators for that study could be notified. The other is that what was the other thing I was going to say? The other is that even if there's not one on there that necessarily is a fit, you can put in that you're just generally interested in participating in research, and potentially if somebody comes along, if maybe I develop a study and we are looking for patients to participate in that study, we might be able to find, oh, there are people on this list that would match being involved in that particular study. And then there are some other more broad things. So one, again, because my research is in the musculoskeletal field, we have a protocol in something called our FIT core that is at University Hospital. Oh, you did that? Is that what you said? Yeah. So the FIT core, it stands for, it's our musculoskeletal FIT core. It's got a catchy name. It's got a catchier name than the other core. But it stands for function, imaging, and tissue. But the thing that most people are actually participating in with that is the muscle function and bone and muscle imaging pieces. And that is at the Clinical Research Center at University Hospital. And you basically go and they put you through your paces like you're a horse getting ready for a race. They do several different muscle function tests, from a 6-minute walk test to there are several different tests that they end up doing. And they also do a bone density test and a body composition test. And they have some special high resolution tests that let us look at really fine detail at the bone, at the wrist or just above the ankle, in ways that the regular bone density test can't do. And that is actually a very wide open protocol. That protocol is open for basically anybody that's healthy or has any disease. And the purpose of that is we want to develop, for some of these tests, we want to build up a good, solid normative database that is good across a wide variety of ages and also is we want a racially diverse normative data set as well. And at the same time, we would then, investigators will then be able to go and say, well, how many people in here have diabetes? And they could look at the effects of their diabetes medicines on some of the bone measurements or on their muscle measurements or things like that. So it's a very broad research protocol, but that's something that any of you could participate in.
But again, you get the copies too, which is great.
And say again?
You get the copies of the printouts that they make of your
they get the copies. Yeah, they give you a printout of the bone, and also I believe they're working on a new one that will give more details about not just how strong you were on a given test, but they're working on publishing this normative data set that will actually not just say how strong you were, but where you fit in with other people your age or at different ages, compared to different ages. So they're working on that, on expanding that scorecard.
What did you call that again?
It's called the Musculoskeletal Fit Score. Let me see if I can find, I can never find the, I can never find the link for the information when I am looking for it. Oh, I think I found it. It's just gotta call it off the server. Because I can copy that in here. This is, here, I can copy this whole thing.
Well, while he's working on that, I want to go ahead and let you guys know, in about 15 minutes, the call is going to automatically shut itself off because that's our limit. But we're going to hang out until then. And yep, he's got the link up in there. So, but after the event, if you ever want to reach out to us, you can go to rarein.org. That's got all of our information on there for email and reaching out. And we're going to be doing more monthly meetups through Zoom. We did that for a little bit before this event, and we don't have any plans for any right now on the schedule, but we're going to be working on those. And I'm really looking forward to seeing all of you again at those discussions. So thank you, Dr. Emel. You can get back to that if you want.
Oh, that's okay. The only other thing I was going to say about research is if you're interested in participating in research, sometimes you can ask your specialist. I think a lot of, not everybody, but a lot of people with rare diseases are seeing a specialist of some sort, and that specialist may know of some information about studies that are available. One other really important place to look that is actually fabulous, it's called clinicaltrials.gov. And you can go on there and search anything. And it's basically, there's a general requirement for certainly any government funded studies, but also most studies that are funded by foundations and pharmaceutical companies end up getting put on there as well. There are some caveats to that. It's mostly going to be interventional studies, but so it won't pick up everything. It won't pick up all of the natural history type of studies or all of the observational studies, but like I said, there are a lot of different ways and situations to participate in research.
thank you so much for talking about that. I know research is a big topic of discussion for many a NORD webinar recently, so that's definitely on point. We really appreciate all the information that you've shared with that. And I'm really interested in learning a little bit more about the Undiagnosed Rare Disease Clinic as well. Could you tell us who to contact if we want to get involved in that?
So the contact information for that one is, I don't have the contact information.
You know what? It's easy to Google. I'm sure we'll be able to find it that way, right?
Yeah, it should. There should be a presence on the web by now for that. There is a process in getting to that, because most of those are going to be people who have been getting genetic evaluations. Not every. They are really sort of focusing on they're trying to be able to figure out the ones that the broader specialty hasn't been able to figure out. That's sort of what their focus is. So often the route to get through that is through the broader genetics clinic. And depending on, because often you get a clear answer from there. In that particular situation.
Thank you for answering that. Does anybody else have any?
They have a pathway towards getting to the Undiagnosed Rare Disease Clinic, but sometimes just knowing something's out there versus not knowing something's out there is key to getting the help you need.
Absolutely, well said. Thanks. Well, we've got a few more minutes before the event will close. Does anybody have a question that they'd like to get in before that happens? You can unmute yourself and jump right in. Don't be shy. If we jump over each other, that's okay. That happens on Zoom. Don't be embarrassed.
You wanted to do a clinical trial for, so I have a 2-in-1 kind of rare disorder. I have FAP, which is like, I don't know how many syllables long. It's familial adenomatous polyposis. And you can get desmoid tumors. And there was one drug, because of course there's no FDA approved treatment options for desmoid tumors. They treat them like they're sarcoma, which is it's a rare cancer. But unfortunately, the clinical trial for that is not taking anybody. It's in phase 3. I mean, we're getting somewhere, but
What's your experience been like working with the clinical trial, if you want to share?
Huh?
Do you want to share what your experience has been like working with?
I haven't worked with them yet. It's closed. So yeah, they're not accepting anybody, unfortunately.
Yeah, sometimes when you hear about a trial, it's I mean, not everybody ends up always making it into the trial. Sometimes they have different exclusion criteria based on certain other conditions or certain other medicines that you're not able to stop, but that they are trying to make sure they can figure out an answer that's real with the medicines. And so that's why they sometimes, especially in early studies, often try to narrow down the population, which is hard because especially if you are interested in being involved in a trial. I would recommend, if you actually know the people that are doing that trial, that keeping in contact with them, because often there's another trial that's going to come along that you might qualify for. And so that's, I have certainly had the experience of being involved in some of our research trials in XLH, where it ended up being, there was so much interest in it that it ended up being kind of competitive to get into it, that it was really, a lot of these trials are really, we refer to them as competitive enrollment, because they don't say your site gets 10 people and your site gets 10 people and your site gets 10 people. They just say recruit however many you can, and when it's full, it's full. I mean, there are some variations on that, but that does mean that that sometimes a given site isn't able to get in all the people that they have in their system that would qualify. But but definitely, you know, especially if you're interested, keep reaching out and to like through the specialist, or if you know the person that locally that's involved in the study, because they will often know when something new is coming along.
Thank you again for answering these questions and being here with us to share your amazing wealth of knowledge. We've been absolutely lucky to have you and Representative Porter here. I'm blown away. We did a good job, you guys.
Yeah, you guys did a great job. Perfect. Well, again, thank you all for your time and joining us this evening. And, you know, we're really excited to continue working on advocacy efforts with you. So that's all from my spiel. Turn it over to John and Sunny to close it up.
Yep. Awesome. Thank you. I'll hand it over to you here in a second, John. I just wanted to say in the chat, I just dropped the link for our website, rarein.org. You can go there and sign up for notifications when we have future events. Like I said, we're going to be doing either monthly or once every 2 months video calls through Zoom, where you can just come and hang out with us and talk about life with a rare disease. It's been a lot of fun in the past, and I'm looking forward to doing it again. So, thanks again, John.
I think getting signed up is important, and please share our information with your friends and family. As has been discussed, there is value in numbers. So spread the word.
Indeed. Yeah, use that Rare Disease Day hashtag. Keep an eye out for other events and stuff. It's Rare Disease Day is officially on February 28th. Because there's, you know, we're trying to do events in all 50 states. So we had, you know, couldn't do all 50 on one day. So that's why we're doing this today on the 24th. But I know I'll be getting involved in other, you know, personal events on Rare Disease Day. It'll be a lot of fun. Just look around. There's all sorts of fun stuff going on the Rare Disease Day hashtag.
All right. Well, thank you all. I hope you have a great night.
Thank you, guys. Thank you again so much, Dr. Emel. I'll see you at the next meetup.
Thank you.
Bye.
Thanks, everybody.
Thank you.